Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany. And today I would like to show you the results of a number of studies that were published this time, not only in neurology, but also internal medicine. Let me start with Parkinson's disease. Epidemiological studies clearly showed that people who smoke have a lower risk of Parkinson's disease than non-smokers. And a study group in Germany, therefore, did a randomized prospective study, which they published in the New England Journal of Medicine Evidence, where they compared transdermal nicotine versus placebo in 100 patients with incipient Parkinson's disease, who at the time of randomization did not need dopaminergic medication. Over 1 year, there was no difference in the cause of the disease. About 1/3 of these patients in both groups needed dopaminergic therapy. That means that nicotine is not effective in preventing the progression of Parkinson's disease. And this also shows that we should not conclude from epidemiological studies how we treat patients. We always have to wait for the results of properly conducted randomized placebo-controlled studies. My next study, published in Annals of Neurology, deals with the genetics of cluster headache. We have good evidence that in migraine, genetics plays a very important role, and there are more than 70 gene loci which have been identified in migraine. Now, this study is the largest genome-wide analysis in over 4,700 patients with cluster headache and 21,000 controls. And the heritability of cluster headache is about 14%. The investigators were able to identify 20 gene loci, and they found an association genetically with cigarette smoking, risk behavior, attention deficit hyperactivity disorder, depression, and musculoskeletal pain. And 3 of the gene loci were shown in migraine. And I think the most important result of this genetic study is that obviously risk-taking behavior and smoking are associated with cluster headache. Now, the next study, published in Lancet, deals with the question whether people who have a large artery occlusion and ischemic stroke undergoing mechanical thrombectomy should first receive systemic thrombolysis or direct thrombectomy. And the investigators analyzed 6 studies with altogether 2,313 patients, and they found no difference in outcome. Now, this is not what reality shows. I think whenever a patient comes with, for example, an MCA occlusion into a stroke center and the angio suite is available, the patient will immediately go to thrombectomy. But if there is a waiting time or the patient has to be transported to a large stroke center, then they should receive systemic thrombolysis. Now, my next topic is extra intracranial bypass surgery in people with occlusion of the internal carotid artery or occlusion or high degree stenosis of intracranial arteries. This study, which was performed in China, was published in JAMA. They randomized about 160 patients to extra intracranial bypass surgery and the same number to medical treatment, and the inclusion criteria was a perfusion deficit on the side of the vascular occlusion. Now, this study was negative for the primary outcome and all secondary outcomes, and this replicates what has already been shown in 2 other studies. And to my understanding, this is the end of this technically demanding surgery. I don't think we should perform extra intracranial bypass surgery anymore. Now, finally, let me move to internal medicine. I think you all know that diabetes and obesity are major health problems. And until a few years ago, we didn't have effective therapy both for diabetes and obesity. And we were not able to decrease the risk of vascular endpoints in these diseases. And this has dramatically changed. The new class of glucagon-like peptide-1 analogs, GLP-1 analogs, were not only highly effective in diabetes, they also showed as a kind of side effect a dramatic decrease in body weight in people who were obese, both with or without diabetes. And a new development here is now that one of these drugs, semaglutide, is not only available as a regular subcutaneous injection, but also in an oral form with 50 milligrams. And this drug, taken over a year in obesity, reduces body weight by about 15%. Now, Novo Nordisk made a very important press release because they had a 5-year study, a select study with 17,600 obese patients who were treated with 2.4 milligrams semaglutide subcutaneously or placebo. And they could show a 20% reduction in major vascular events like stroke, myocardial infarction, and vascular death. And this shows that the decrease in body weight is not only a cosmetic result, it has major impact on healthcare systems in reducing vascular diseases. And there is still progress. We have now new drugs which combine two modes of action, GLP-1 agonists, and at the same time, they work on the glucose-dependent insulin-tropic polypeptide. And one of these new drugs is tirzepatide, which has shown also a decrease in body weight in obesity by about 15% in 1 year. Now, beyond this, the drug also resulted in decreased blood pressure, lower cholesterol, and a number of improved metabolic parameters. These are good news. The not so good news are, number one, these drugs are not approved yet for obesity treatment in all countries. They are very expensive. They have side effects. And obviously, you need to treat lifelong, because when you stop the treatment, the body weight increases again. So, dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany. Thank you very much for listening and watching.